Quick disclaimer before you listen. The World's Okayest Medic podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. The lighting's all fucked up, I feel like. Couldn't get the lighting right, but here we are with April listener questions with Ashley. And as I predicted, I have a man cold again. I had a kid with croup the last night of my last tour, and I get sick every single time I have a little kid with croup.
And then we have to open the man ICU here.
Yes. Some news. We have joined with Counterculture Inc. I think everybody knows that by now. We have gotten that started. I thank the followers because I recorded with the Tone Alert podcast this week. They are part of Counterculture. And they said, hey, some of your followers have started following us. And they said, you have some very loyal followers, which I have heard from many people over the years. And that is absolutely correct. So just some appreciation to the followers. Everybody knows I'm now an affiliate with Frontline Optics. Use code OKMedic at checkout for some baller sunglasses. Same with X Shears. I am an affiliate. Those are the shears I use at work. Use code OKMedic. Had some new people join the Patreon this week. Thank you very much. Your support means a lot. And with that, oh, by the way, speaking of loyal followers, I've gotten to know the Pocono Mountain EMS agency in the Poconos, go figure. I did an online CEU lecture for them about drownings, which you know a lot about.
Unfortunately.
Because listen to the drowning episode. Her dad drowned. Long story. RIP. But as a thank you, they sent me a care package, and included in it was a candle that is the Smells Like the World's Okayest Medic candle. I don't know if people can see that.
Very cool.
Yes. It smells like balls.
Oh, no. That's terrible.
No, I'm joking. No, it smells good.
Smells
yeah.
really good.
So I have, from my loyal followers over the years, I've gotten hot sauce. I now have a candle. I've gotten...
Beautifully.
Yeah, Michael gave me that beautiful World's Okayest Medic, like, glow-up thing in my patch.
Mm-hmm.
It's awesome. So, love the followers with that. And also, last time I was editing a listener question episode, I bang on the table when I'm making a point, and it comes through the microphone, and it was driving me fucking nuts.
Oh,
so if I start to do that, please tell me.
Mm-hmm.
Yes.
Okay. All right.
All right. Let's get to the first question.
All right. Lidocaine or amio? When should you use one over the other?
I don't think it matters. When I was in paramedic school, there was this giant push to use amiodarone over lidocaine because they said, oh my God, such better outcomes. And the AHA jumped on board with it and said, yes, a large study has come out that shows that amiodarone has much better outcomes as far as ROSC in VFib and VTAC patients. So everybody jumped on team amiodarone. Now, I don't think it matters. If you look it up on PubMed and look at different studies, it tends to, like, some say amio's better, some say lidocaine's better, others say procainamide. At the end of the day, I really don't think it really matters which antiarrhythmic you're using. Disclaimer, I'm not a pharmacist, so I don't know. But I will say that I think that the preference for amio in ACLS is yet another example of the American Heart Association being a greedy, money-grubbing organization that just will take money from whoever and say whatever. They are whores. So this whole push, this giant study, and reference in the paper, it was a 2002 study published in the New England Journal of Medicine by Doctors Paul Dorian and Dan Cass. I don't know them, obviously. I have read the study. It seems like a well put together study, but it heavily, heavily, heavily favored amiodarone. If you read to the absolute bottom of the study and then you Google Dr. Paul Dorian and Dan Cass, you will find that they receive money from, and the study was sponsored by the Wyeth Erst Laboratories. Now, if you Google who makes amiodarone, what do you think the answer will be?
I'm guessing the Wyeth Ayerst Laboratory.
You are correct. So Wyeth Ayerst makes amiodarone. They funded a study. The AHA said, oh yeah, got in bed with them. I am alleging, that is my opinion. I don't have any facts, so lawyers don't come after me. This is just my opinion, but I don't think it matters. We use lidocaine in New Jersey and Pennsylvania. We have amio on our trucks. I think both don't do a whole hell of a lot as far as ROSC, at least that I've seen. The things that I have seen anecdotally that really help are good CPR and prompt defibrillation.
All right. That's good. All right. Thoughts on questionable AMAs done by departments in high volume areas?
Well, I had a couple of thoughts about this question. First off, I don't think that questionable AMAs are good in any area, whether it's a high volume urban area or not. I mean, I have definitely seen some podunk rural EMS crews show up and be like, I don't think you need to go to the hospital. But I do see what this person is saying. There is a degree of complacency when you work urban EMS because you go to low acuity call after low acuity call after low acuity call, especially if it's a lower socioeconomic population. And I'm not faulting those people for calling 911. There are definite barriers that they have facing them in their life. And sometimes it's the only access to healthcare that they have. But yes, I have seen city EMS sometimes be like, you don't need to go to the hospital for that. That is not okay. But I was saying, what makes the AMA questionable, though? Is it one of those? Because that's never okay to try to tell somebody that they don't need to go to the hospital. Your problem is not a problem because you just don't know. You could be the best paramedic in the world. You're not a doctor. You don't get to diagnose their problem. You want to do that? Go to medical school. Very litigiously problematic and unethical, in my opinion. That being said, I have definitely done my fair share of questionable refusals on patients that should go to the hospital but don't want to go to the hospital. It is not our job to prohibit a person from making a poor life choice. We inform them, we educate them, we persuade, we strongly recommend, we assess them, we tell them what we find, we tell them the risks. But if somebody wants to make a dumb decision and not go to the hospital, and barring acute mental illness, delirium, altered mental status, suicidality, like overt intoxication, if they want to make a dumb choice and not go to the hospital, that's fine. That's their right.
So when you say you've had your share of questionable AMAs, it's a call where you're like, like, I really think this person should go to the hospital, but the patient is able to make the decision, and that's why it's questionable because you think they probably should go, but you have to
Yeah,
let them.
I had one last week.
Yeah.
Guy in his
Yeah.
40s. He has a weird neuro history. He's had a head bleed, and then 2 years later, he had a carotid dissection that caused an ischemic stroke. He had a syncopal episode without any warning. And then questionable, was it convulsive syncope or did he have a seizure after he hit the ground? I show up. He's alert and oriented. His assessment looks fine. And his wife is crying. His 2 little kids are freaking out. And he is adamant he is not going to the hospital. And as one of the BLS guys said to me when we cleared the call, he was like, of all the people who call that don't need to go to the hospital, this is the guy who refuses.
Mhm.
And I told him everything, that I thought he was making a bad choice. I even told him, like, I didn't use these words. I told him in so many words, like, I kind of think you're a dick because it's not all about you. Like, look at your wife and kids. They're freaking out. But when push comes to shove, we're not the police. We're not officers of the court. We can't force you to do anything. We call med control, but the med control doctor can't force you to do anything. So, always be very thorough with your refusals. It's not just, if somebody says, I'm having chest pain, I'm not going to the hospital. I wouldn't just be like, all right, dude, like, bad idea, but sign here. No,
Yeah,
you
have
gotta
to try a little bit.
Yeah,
Some
absolutely. You
effort
have an
into it.
ethical duty, but at the end of the day, if they want to sign a refusal, take their life into their own hands, it's their own life. Let me say that this is yet another nail in the coffin. I don't know if nail in the coffin is the right adage or saying for this, but this is yet another slam dunk would be better reason we should be wearing body-worn cameras.
Mm-hmm. Yeah, because you can see the whole discussion, the whole situation, developing. And
do you know they even have programs now? People are against body-worn. A lot of EMS providers are against body cameras. I found something out 2 weeks ago about body cameras that I think would make 95% of EMS providers on board. What do EMS providers hate doing more than anything else usually? Charting.
Oh.
There are body cameras and programs now. You show up to your station, you take off your body camera, you plug it into the computer, and it AI generates a report for you.
Wow.
That is nuts.
I guess it's kind of similar to like a what is it in the hospital? They sometimes use a program, Dragon, where it's like a dictation program, but I guess it's AI instead now. It picks.
Yeah, I know
that way.
AI's.
You'd have to. I guess you'd still have to kind of like double check everything. I don't trust AI for anything, honestly, but a lot of people love it. But that is pretty cool. I do know that some of the hospitals are even doing that now. I think Cooper actually, either MD Anderson or Cooper, somebody does it where your visit is actually recorded and then it like dictates the chart for them. So the provider doesn't have to do that. That is pretty cool.
Yeah, certainly would be cool. And having done QA and expert witnessing, and some of the charts that I read look like they are written at a fourth grade level, sub fourth grade level. Yeah, maybe that would be a good thing.
It's true.
Okay. Next question.
All right. Is there really a place for Benadryl in pre-hospital medicine, especially if transport is less than 20 to 30 minutes?
Okay. I don't want to be a dick. I don't know who asked this question. I am sure it was asked by an excellent EMS provider with the best of intentions. So please, if you ask this question and you're listening, don't take this personally. But questions like this drive me crazy because I didn't look up how long Benadryl takes to kick in. I didn't. But you hear this a lot with Solumedrol. Because they're like, Solumedrol takes 45 minutes to an hour at least to start to have an effect. Like, why are we even giving it? Like, we don't see any benefit from it. Well, it's not about you, dude. It's about the patient. So if we can get that Benadryl or that Solumedrol or whatever drug on board early, it's going to have a maximal benefit for them. Because what's going to happen when you go to the hospital?
Yeah, I was just going to say, you're going to have an added weight is going to just... the time is going to tick by.
Totally. I had years ago, I had a learning experience because I went to a doctor's office for a 30-year-old with chest pain. And from the entrance to the doctor's office, you could see the ambulance bay to the ER because it was on the campus of the hospital. I put her on the monitor. She is an SVT. And she's got a good blood pressure. She's pretty stable. She's not short of breath. She didn't meet any criteria for cardioversion. She just had like this 5 out of 10 chest pain. She was a little uncomfortable, a little anxious. And I thought, you know what? I could see the ambulance doors. I'm just going to call them ahead and we're going to roll in and I'll pop an IV in the 2-second drive to the hospital, which is what I did. So we go in. I go in, hey, this is the SVT patient. And I get this like, okay, from the charge nurse. We wait. The patient gets registered. We then go to a room. The nurse then comes in, assesses the patient, gets the doctor. So a resident comes in, notices that it's SVT, then brings the attending in, and they're discussing, should we give adenosine or should we give metoprolol? And meanwhile, I'm thinking, I should have just given the patient the adenosine and saved her all of this rigmarole. And like 45 minutes later, she got adenosine and got converted. So it is not always about seeing a benefit for the patient.
Immediately when you're with them.
Yeah.
Yeah.
No, get the ball rolling. I am a big believer that we get the ball. One of our jobs, I see I started banging on the table, is that we get the ball rolling for healthcare for them. because we can treat in the field. It may not be life-saving, but it may save them some steps and save them some time because the process of healthcare in the hospital is so inefficient. So yeah,
Yep, I agree.
there is a place for Benadryl in pre-hospital medicine. That being said, it is a misconception that Benadryl is effective in anaphylaxis. Should you give it? Yes, Benadryl is an antihistamine, but keep in mind that in anaphylaxis, the culprit, you get a little bit of histamine, but the culprit is a whole lot of SRSA, slow releasing substance of anaphylaxis, which I think they could have done a better job coming up with a name. But Benadryl doesn't do jack squat for SRSA. Epinephrine is what combats SRSA.
I was going to say, I think you did an episode on this like a long time
I've done a
ago.
lot of content
Like,
on this. Allergists have moved Benadryl, I think, to like a tier 3 or tier 4 intervention for anaphylaxis.
Okay. All right. When and
I keep sniffling, that damn kid.
when and how to use sedation facilitated intubation in a service without paralytics. Also, I'm curious about your thoughts on a state not allowing RSI for street medic.
Well, considering I work in Pennsylvania where we don't RSI and we do sedation-assisted intubation, I will give credit to Dr. Bledsoe and other physicians in the Pennsylvania community who are working very hard to get us to be able to RSI. They're calling it the DAM protocol, which I really like, DAAM, drug-assisted airway management. I think it's a great protocol. They are all about it. They're very supportive. But in Pennsylvania, there is this it's not a nicety that they have to go through. By state law, in the EMS Act, there is a medical advisory committee that they have to go through. It's not like the medical director can just wave a wand and say, hey, I want paramedics to do X, Y, or Z, like it is in Texas. You have to go through this committee, and there are some old dinosaurs that just won't die that are on the committee and are not about it. But I am told the protocol is coming. That being said, I think that sedation-assisted intubation only is dangerous. I have had some sedation-assisted intubations go straight up sideways. I have had plenty of very well-conducted SAIs where the sedation did not do the trick enough. I had that burn patient where she didn't get relaxed enough with the ketamine. I had a head bleed patient that did not get relaxed enough with ketamine. I think that sedation only is dangerous. Dr. Jose Torres, the Sangria Loving Airway Doctor on Instagram, he agrees with me. He did some content on this, that sedation only is dangerous. I do not agree with this, just the tip methodology of giving tools to EMS.
And just using it just enough.
Either
minimum.
give us the whole protocol or tell us we can't do it.
Yeah.
I mean, I have had a couple of SAIs go sideways, and I have thought, if I knew it was going to be like this, I would have just sat the patient up, put a non-rebreather on him, and driven 50 minutes with him. I have done countless RSIs. I've done a ton of RSIs, and I have never had a situation where the patient is not relaxed enough, because that's the point of the paralytic, to totally relax them. And this is dinosaur old thinking that, well, the paralytic is, if they push a paralytic and can't get the tube, then like the patient's going to die. If you can't get the tube, that happens. You manage them.
Yeah.
BLS or a supraglottic airway. I don't want to say no big deal, but really no big deal. As long as you recognize it, they don't get hypoxic, they don't hemodynamically crash. The thing that kills people in drug-assisted intubation is the induction agent, because it causes a hemodynamic crash if you haven't resuscitated the patient. So why on earth would you give us the dangerous induction agent that may cause the patient to crash and then not give us the paralytic that is going to appropriately relax them? So now you have a crashing patient potentially because you've tanked their hemodynamics, and you have a patient that isn't relaxed enough for you to pass a tube. Bad, bad, bad juju. But as you know, we love Dr. Bledsoe. I know like Dr. Hagmed is involved in EMS in Western Pennsylvania. He's very pro the DAM protocol. Dr. Schiffer who I was supposed to record with this week, but screwed up my schedule. So I'm recording with them this week. Very pro paramedic RSI in Pennsylvania. So it is coming. I've heard it has been coming for like 4 years now. I will believe it when I see it, but I do think it is actually happening. But SAI, or sedation only, is bullshit.
All right. What do you think about BLS chase cars for non-emergent calls in a big city filled with fire apparatus?
Bad idea. I think that this is one of those things that sounds like a really good idea at face value, or I shouldn't even say at face value, because I think that might be a little dismissive and maybe even a little disrespectful. I think it's a bad idea. It seems like a really good idea, but EMTs are not equipped to assess patients and do non-transport dispositions with them. There are lots of non-acute conditions that people call EMS for, and not immediately life-threatening conditions that can have severe, drastic complications down the road. Like, hey, my skin's yellow and I'm a little tired. Like, that's not an ALS patient, but that patient may end up in an ICU and then end up on a helicopter going for a liver transplant evaluation. Or, hey, I've got this sore on my finger. Well, an EMT may respond, what the hell is the EMT going to do about that? Like, that patient probably needs to see a doctor, whether they get transported to the ER or whether they go to an urgent care, they need to see a provider of some sort. So I think that it sounds like a good idea, but I don't think that it's really useful. What is useful? What were you going to say?
I was going to say, could that, I know some states, I think Arizona might be one of them, or New Mexico, they now will get on the phone with like an NP or a PA and pre-hospitally, like they'll assess them and they'll set up follow-up care if they feel like the patient isn't emergent to go to the hospital, but they should be seen at some point. I could maybe see BLS being used in that circumstance, but even that is kind of like, it's still, like a fine line.
Yes, there is a role for community paramedics. I'm sorry. I know people think I always shit on EMTs. I value EMTs. They don't have the training to make the important go or no go decisions. They just don't. And I'm not disparaging any particular EMT. Yeah, you have a paramedic show up who can FaceTime an NP or a PA or a doctor. Yeah, absolutely. Hey, look at this sore. You think they need antibiotics? What I do think is useful for non-emergent calls, and not just a big city, but really anywhere, are the provider response units. Like Austin, Travis County, I believe they use PAs. LA uses nurse practitioners. I think that's freaking great. I mean, what do you think? Like, hey, 911 call comes in as difficulty breathing, 6-year-old male, and it's strep throat.
Yeah. So you're saying the PAs or the NPs they actually respond to the calls, they assess the patients and then determine, if I mean, I think that's awesome. I think that would save a lot of people from being transported unnecessarily, but,
and then you think about the socioeconomic value too. Like, let's say it's a single mom with 3 kids, low rent apartment. Her kid's got strep throat. She's concerned. She doesn't know any better. She doesn't have any help. So she calls 911. And now she misses work.
Right.
Because she's got to go sit in the ER. You can show up and be like, hey, this kid needs penicillin. And you know what? I actually have some penicillin. Here's the first dose. Here's a prescription.
Yeah.
Sometime in the next 24 hours, get to a pharmacy and get this filled.
Yeah. I mean, that's awesome if they can do that. I guess some of those programs, they must carry like point of care type testing things for those certain circumstances, and then other things you can just kind of diagnose by assessment only. But yeah, that's awesome. That I agree with you about the EMT, just not having enough training to be able to definitively say, like, safely, this patient doesn't need to go anywhere right now. And that's not to say that there are not EMTs that have a higher level of, thinking or critical care or critical thinking, or that they could not do that. But in general, across the board, like with their scope, I don't think that there's enough training.
Correct. The same goes for paramedics too.
Mm-hmm.
to a degree. If somebody called 911 and they've got some cancer condition or whatever condition, we're trained a little bit about a whole lot of different things. We're not trained like deep level critical thinking style knowledge about many of the conditions. Like I was talking to Bert, the medical director. He was talking about antibiotics, and I said, I don't know jack shit about antibiotics, like what you use for what. I know basic, like start with broad spectrum and then like narrow spectrum when you've identified the culprit. And he's like, you guys aren't trained in it. He's like, you don't need to know anything about antibiotics other than give Ancef because it's in your protocols for open fractures. So yeah, don't think I'm shitting on the EMTs, but
Yes.
I'm just saying that no, I don't see any value in having BLS chase cars.
And we never ever want to come across that way because that we do not feel that way at all about
Sometimes
EMTs.
I do.
Well, I guess there are certain circumstances, but we both started as EMTs. We've both been paramedics. I'm a nurse, and I love EMTs and I think they have great value. So it's not just because we disagree with, a question or a comment about a certain practice does not mean that we don't find value in EMTs. Okay, so next question.
Sure.
All
Unless
right.
you have anything else to add.
I don't think so. Not for that.
Would you, as a nurse practitioner, be comfortable responding to a call like that?
I mean, if I thought that my scope was to be there to assess patients, whether or not they needed to go to the hospital, and you're acting as more of like a primary care provider at that point, I would. At this point, I've been out of EMS and pre-hospital medicine for so long that I wouldn't want to be responding to things that were truly like emergent critical care because I've been out of that realm. So I guess it would have to be somebody who would be willing to respond and either be able to do primary care and also something really, critical.
Let me ask your opinion on something since you did peds primary care. And this is a topic that has come up at work. Croup kids, they are often much scarier looking than they really are.
Mm-hmm.
And while they have airway narrowing, I said that correctly, far less than 1% of croup kids need to be intubated.
Mm-hmm.
And if you read the literature on it, even though it's less than 1%, that's probably because people unnecessarily freak out and tube those kids. And it said barring some, like a super special needs kid or a kid with cancer who's immunocompromised. It said barring a situation like that, virtually every otherwise healthy croup kid who gets intubated does absolutely fine. So we now have a protocol. We follow the Children's Hospital Philadelphia protocol. We give racemic epinephrine and we give dexamethasone. The question is, do these kids even need to go to the hospital if we're giving them that treatment?
Yeah. So, I mean, a lot of these kids typically are treated outpatient.
And we give
anyway.
Tylenol too.
So a lot of these kids are treated outpatient anyway if the parents bring them to pediatrician during the day and, we give them a dose of dexamethasone and send them on their way. A lot of times they don't even end up going to the hospital, period. So I do think that there are many kids that probably would not need to be transported. But again, it's one of those things where it's like, you as the paramedic, do you want to make that call when you don't really know if they're going to worsen or not, it's just hard because with the pediatrician, you're going to likely follow back up with them again the next day, call to check in on them if they're worrisome to you.
The question is, why can't we do that? Why can't we call 6 hours later?
Yeah, that's
and say,
true.
Hey, just checking in.
Check in, even the next day. And then at that point, recommend them to go in and be seen if they're not getting better. So, I guess it really has to be specific protocols to certain areas and what the comfort level is of the providers there and of the medical directors and that kind of thing.
The mom, I felt bad for the mom of this kid. They had a lot going. The kid that got me sick, even though he got me sick, I felt bad because the family had a lot going on. And I'm treating the kid, and the mom says, if you do this, she had no medical training, but she was smart. She said, does he even need to go to the ER? And I was like, no, but yeah, you're going to the hospital.
Mhm.
Like, yeah. So, people get mind blown when they find out how we give dexamethasone. It's super simple, but,
What,
um,
orally?
yeah,
What?
orally, but it's so funny. Like I train the paramedic students, and I tell them this, and they're like, really? You drop the IV solution, like you're going to
Mhm.
give it IV, and then you squirt it in their mouth
Mhm.
because it's a tiny little volume for
Yeah.
them to handle.
Yeah, and, it's amazing how well it does work for the majority of kids. There's one dose, like, a couple hours later, it's like, wow, it's amazing.
Yeah, but we don't see that happen on the ambulance. So, like,
But
should we even give
it
it?
does happen, though. And, again, what you said at the beginning, croup kids, they tend to be way scarier sounding than they actually are.
Bronchiolitis, too.
Bronchiolitis too. Bronchiolitis parents tend to get really freaked out by the breathing and how the child kind of looks and the sound of the breathing. More often than not, they end up doing just fine. And years ago, they actually ended up where they used to give nebulizer treatments a lot for it, and that's not even really recommended anymore because it doesn't really help that much. So, um, it's more like watchful waiting and but it can be nerve-wracking, so for providers and for parents.
Yeah. All right.
All right.
Uh,
What are some precepting tips for when your student seems hopeless?
Take vacation. Well, first things first, you have to do some self-reflection. Am I failing them as a preceptor? Because I have preceptor burnout is real. That came up in the comments on my reel yesterday. That is definitely a real thing. Where you find yourself getting pissed off, or you find like, yeah, you're doing fine, and like blah blah blah. So ask yourself, are you doing them the best job that you can possibly do? Also, you have to be very specific with your when critiquing your student. That is a big pitfall that people fall into. I still fall into that pitfall of, hey, I think you did a shitty job on that chest pain call. Like you didn't manage the scene. Your assessment was scattered. Like you didn't do a good job. And I will now find myself when I've taught myself to be very specific, and I will be specific to the point where I have a stopwatch. Chris Johnson from Newcastle County taught me that technique
Oh,
where
really? I didn't know that's where that came from.
where I
Huh.
time the students, because I will sometimes it keeps them in check and it keeps me in check, because I can be like, hey, unacceptable. It took you like 9 minutes to realize that we need to do a 12 lead in this pale, clammy, diaphoretic chest pain patient. Not that I would let them wait that long. But then also I will find myself like rolling my eyes, putting my hands on my hips, be like, oh my God, are you going to like do this like this today? And I look down, it's been 17 seconds. Like, all right, I need to be fair to the student. But I am very specific and I keep track of what they're doing and I write down things. And I find that I'll be kind of like, that student didn't do a good job on the call. And I'll be like formulating my critique and writing specific things down. And then I'll find myself going like, you know what? They're a sub entry level paramedic student. Like, as now that I'm being specific and writing specifically what they did wrong, like, they didn't do that bad of a job. Like, it may not have been beautiful. It may not have been they may not have been a well oiled machine, but
They're not
they
meant to
did
be at
cover
that
all
point.
their bases, like, and we can work on shoring that up and making them flow better. And a lot of times that's just going to take time. But also, if they do indeed suck, you need to be very specific. You need to be, three of your last four IV attempts you didn't get. Um, you know, when you want to administer a medication, I always ask the student, how does the medication work? Why do you want to give it? The last three times I asked you, I got blank stares. You need to work on your pharmacology. You need to be very specific. And then you need to develop an action plan. And you need to use that specific data that you have obtained that is causing them to not do well and apply it to those action plans. So metrics, timeframes. Another thing that I have done is I will take the thing that the student sucks the most at and I will remove them from the call. Like, I will run the call and I will have the student only do that thing.
That that
for
they're
a few
not good at.
calls that they're not good at. IV is such an easy example.
Yeah.
You suck at IVs. They
That's
get
what you're gonna
stressed. They go to the patient. They're so stressed about the time coming for them to start the IV that they bungle the assessment because they've got the IV in their head. And I'm like, I assess the patient. I will
You
develop
put
the
the IV
plan.
in.
All you do is the IV. That's
Mhm.
all you got to worry about. And I will coach you when it comes time to doing the IV. So that does work. Another thing that works is send them to another preceptor. I know that sounds like you failed them or you're passing the buck, but sometimes it is that simple. Different FTOs click differently with other people. I'm not saying it's the FTO problem or that that's going to be the fix for the student. If the student sucks, you can bounce them to like 17 different preceptors. They're still going to suck. But sometimes it is a matter of just having a different FTO
Yeah,
work with them.
I agree. I think all of those different suggestions or kind of tips and tricks are helpful.
Yeah, and don't be afraid to have hard conversations and make decisions. So I had a student before, and she's going to know exactly who she is when I'm talking about this. She was riding with us in Chester County, and where we work, we're not slow, but we're not running call after call after call after call after call like you are in the city. And she had no EMS experience prior to going to paramedic school. And she wasn't doing a good job. She was smart. She knew the paramedic school material. She had great work ethic. She was driven, but she just didn't have enough exposure. And I had the hard conversation with her, with the school. I said, we can't have her. I recommend she goes to Crozier, which is now shutting down. I said, send her to Crozier, have her run calls in Chester
Constantly.
where she's going to be exposed to patient after patient after patient. And it's not even just the patient stuff. It's, all right, how do we get this 500-pounder out of their house? Like,
Yeah, from the fourth floor.
it's the
from
operational stuff too, and the scene management and situational awareness. And I think she would say she's great now. She's a flight medic. She's a SWAT medic. She's just like me. No, I'm kidding. But she's great now. And I'm not saying it was because of me being her FTO, but like I punted her.
You recognized
I
that
said-
she needed a significant change, one that wasn't going to happen like where she was currently precepting.
Yeah.
Yeah.
So you got to think what's best for the student.
Yep. Okay. Are pediatric BVMs too small for adults with adult masks?
Good question, because there was a few years ago, there seemed to be this big push to go pediatric BVM for adults. And then some manufacturers saw this, were like, hey, we can make some money off of this. So they produced pediatric BVMs, adult BVMs, and then small adult BVMs. So the big worry is that BVMs have
to help prevent
they have
barotrauma? Or?
Yeah, they have much too high of a potential for a tidal volume. Like if I squeeze an entire adult BVM, that's too much friggin' air. You're going to cause barotrauma, volutrauma. But so the theory is that the reservoir is too dangerous. It is too big, and there's too much potential for error. And one study did show this. They said even the pediatric BVMs have too high of a reservoir that can cause too high pressure ventilation. It was 807 mLs for the adult BVM and 630 mLs for a pediatric BVM, which is still a hell of a lot. But this is one of those things like EMTs in chase cars responding to non-acute calls that may sound like a very good idea, but in practice doesn't work. We have become, and Melody kind of alluded to this on a podcast when she talked about starting higher on your ARDSNet vent strategy she said she always starts at the 8 mLs per kilo of ideal body weight. I don't want to go too deep into the weeds, but she said that, yeah, you do need to be worried about overventilating your patient. That is right. She said, but we've become so concerned about overventilating our patients that we are now underventilating our patients. And there are 3 studies, citations will be in the show notes, that do show this, where they used either small BVMs or pediatric BVMs. One was a simulation study, and the others were with real humans. I don't think they were randomized control trials. So, Brigham and Women's, they would never have listened to this. But I digress. I can hold a grudge. Or I'm sorry, Beth Israel. It was Beth Israel that was like, oh, there's no RCTs that.
Oh.
Yeah. By the way, they are still trying to block pre-hospital blood in Massachusetts. The Medical Standards Committee or whatever it's called, they are pulling some shit where the doctors who are involved, and one of them is a medical director for one of the air medical services. Now, this is what I'm told. I have not seen this firsthand, that when the topic comes up of should we move the pre-hospital blood protocol for ground transport ambulances, should we make it statewide and not just a pilot, that is in the new business section of the meeting. And by the time they get to new business,
The meeting's over.
all these doctors suddenly are like, I can't stay. I have to leave and go to another meeting. So the committee is like, well, these doctors aren't here to talk about it, so we'll just table it. And that is how I'm told that's how it's being blocked.
Awfully convenient.
What little dicked, like, piss ants. These are the same people who will post Ukraine and Palestinian flags and talk about all the social justice stuff and equality on their social media profiles. And then when there is something that we can do that is the definition of providing life-saving, equitable care at the point of injury to a poor person, or they're just like, no, because that'll interfere with our profits. They don't say that.
Yeah, that's crazy.
But that's what it is. Fucking hypocritical douchebags. And I will never get off my high horse about this. I'll post it again. Steve Wood, who they hate him. They hate me. They really hate Steve Wood.
They hate him as much as Phillips hates you.
Yeah, that is true. They really hate him. He has a petition to disband that committee. So I posted a link to it. I'll post it again because it does need signatures. It is a self-appointed committee. So he tried to appoint himself to it, and they said, you don't have the qualifications. And he said, well, where are the qualifications? And they said, well, it's a self-appointed committee. And he was like, exactly.
I'm self-appointing myself.
So that's what they're dealing with up in Massachusetts. I went down a huge rabbit hole.
Yes, you did.
What were we talking about?
BVMs, adult BVMs,
Okay.
why in theory it's good.
I don't think any of these studies that showed that these small or pediatric BVMs for adults, they weren't randomized control trials, but these studies did show that it doesn't work in actual practice. They found that all around, whether you are using those BVMs with a BLS airway maneuvers or a supraglottic airway or an endotracheal tube, they studied that in the simulation study, they all delivered inappropriately low tidal volumes. So much so that when using an oral pharyngeal airway with a BVM, they didn't have an appreciable tidal volume delivered to the patient. So they couldn't include that data in the final analysis of the study. That's how low the tidal volume was. And then the other two studies showed that there was worse ROSC when using a small BVM, a 7% absolute reduction in ROSC.
This is all very interesting. And I have a question. I'm trying to think through it right now. So if they were using the pediatric BVMs with adults and they were finding that they were having much lower success with them and it was delivering less volume and everything, I would imagine that the same thing would happen with adult BVMs where it would deliver less volume, which then would not be causing so much barotrauma. So I'm kind of confused about that reasoning.
Say that again?
Okay. So if you have a pediatric
Yes.
BVM and they found that for adults, it was not delivering enough volume, is that what you said?
Yes.
Okay. I would imagine that with an adult BVM, it would still deliver less than what was expected if that was happening with a pediatric BVM, like if it was delivering lower amount. So then if an adult BVM is delivering less than what is expected, does it really still produce the problem of so much barotrauma then. I don't know if
I think
it's
that
making
all this
sense,
stuff
but
about barotrauma with BVMs is probably, it's real. There's a risk for sure. I think it's probably one of those things that is kind of like dogma and overstated.
yeah, I don't know. And for the listeners, I don't know if you were following my question or if it made sense. I'm just trying to like work through it in my head because it's, to me, it sounds like the device is delivering less volume than expected. And if it's happening with a pediatric device, I would think that the same thing would happen with an adult device. It's the same device. So I would think based on you squeezing the bag, it's probably delivering less volume than you're expecting it to.
Yeah.
So then it's kind of like, well, is it causing as much trauma as we think? And you said you think it's more.
Yeah. I don't think the actual squeeze is the problem when I see people bag valve masking. And I think research supports me on this. If you look at like hyperventilation research, I think it's the rate that
Okay.
you're squeezing it. Because I mean, we'll tube someone on the helicopter where we have RSI, not just sedation-assisted intubation. And while we're getting the vent ready, like I'll hand the BVM off to a firefighter.
Like,
no offense. They're like, it's
well,
like, oh, slow it down.
well, yeah,
Once every 6 seconds.
Sure,
like,
it is the rate
you know,
because you're building up all of that air and not
Yeah.
having enough time for it to escape. So,
yeah.
all right. Well, sorry, I went down a rabbit hole as well, but
No,
it was
it's
just
fine.
something that I thought of. Anything else with the BVMs?
No.
No. Okay. Advice on managing time while working full time as an EMT and doing medic school.
I did it. It sucks. There's
Yeah.
no doubt about it. It's one of those things like having a migraine or a hangover. It sucks. You just got to power through it. I wish I had some hack to tell you. It just sucks. And I will caution people to say, I get it. Like, you got to do what you got to do. I would caution you to not slip in one area because you are overdoing yourself. I know that's easier said than done, but I have seen EMTs fuck up in medic school because they're working so much as an EMT. And then I have seen medic students who are doing great kind of be lazy at work. And they're like, which I get. It's life, but it sucks, grin and bear it.
Yeah. It's, I don't think there's really anything necessarily to do with anything specific for managing time. I think you did you worked like day shift sometimes and then you had night classes or would work on the weekends.
Yeah, it sucked.
Yeah, it's a lot.
It sucked.
I mean, the one thing is it's temporary. It's short amount of time in the grand scheme of things. But yeah, I agree. You can't let one area slip.
Yeah.
Okay. How do you advance a department full of fire medics who love old medicine, fallacies, and not EBM?
I love how they said fire medics. This isn't just fire medics. This happens with every paramedic or any paramedics. First off, be aware that not everybody is as into evidence-based medicine as you may be. I'm into evidence-based medicine. I also have done education. I have noticed that there are times when I am like getting really passionate about some topic and I'm talking about the research, and I could see a couple people who may be great providers in the crowd just looking at me and they're thinking like, I don't give two shits about these studies or what you're saying. Just tell me what I need to do to be a good paramedic. So just keep in mind that not everybody is going to be as much of a zealot as you are. Which is fine because people have different interests. Also ask yourself, and I've been guilty of this too, is said evidence-based medicine that you are trying to impart on the masses, is it applicable or are you just kind of jacking yourself off with what you're teaching the people? That being said, I think what this person is talking about is getting out of the old habits die hard stuff, like backboards, don't use backboards, or hey, no albuterol, or like albuterol does not cause flash pulmonary edema, stuff like that, or instituting POCUS. I mean, I was one of those naysayers before it said, no, we don't need POCUS. So yeah, use evidence, be enthusiastic, give them a good presentation. I mean, those are kind of common sense things. Some things I have learned from trying to change practice is don't try to change too much at once. Focus on one, maybe two things at a time. Overwhelming people with all sorts of brand new stuff is problematic. They're going to be uncomfortable. Not everyone, but a solid chunk are going to be uncomfortable. And don't overwhelm them. Change one or two things at a time. Um, Sometimes if they're totally resistant to it, you got to get the medical director involved. You got to get admin involved. And sometimes this isn't like inspirational Jocko Willink leadership stuff. You got to be like, hey, I don't care if you don't like it. Like, this is the way it's going to be. You are going to do a 12 lead on these patients. You are going to put a POCUS probe on the chest of the patient. You're going to terminate a code. Uh, Firefighters, especially, it is a very paramilitary chain of command type thing. So if you can get a battalion chief to tell the crew, you will use POCUS on this patient, they're going to do it. And then another controversial take, sometimes you have to resort to shame. That's what I have done with the old heads who still say that you should withhold albuterol on the patient with a history of heart failure. Also with people who are against pre-hospital blood. Sometimes you got to make them look stupid. Controversial take, you may not agree, but that's what I think.
Yep.
And now we will get to our last question.
All right. Should AEMT become the new BLS entry level for EMS?
I go back and forth on this all the time. On one hand, I say yes. The bar for becoming an EMT is far too low. Again, that is not me saying there aren't great EMTs or EMTs aren't useful. There are wonderful EMTs, and I'm going to work with some tonight when I go into work. But there's also some morons who pass the National Registry, and I've said no less about the human body than 8-year-old Angie, who's upstairs right now, which is not okay. So I have thought that, I have thought before, EMTs, fine to do the discharges, the dialysis runs, that's fine. When people call 911, they expect a trained professional to show up. And I have thought AEMT would be good for that. But this is another thing, like the pediatric BVMs or the chase cars with EMTs on them may sound like a good idea, but in reality might not be a worthwhile thing because it's 180 hours these days for EMT class, 240 hours for AEMT. That still pales in comparison to like what a paramedic or a nurse goes through. Going from 180 hours for an EMT
60-hour difference
to 240 for AEMT. Yeah, that's like 5 extra days of class and an extra clinical day.
Yeah.
That's really not that. It's not that much. On the flip side, sorry if I offend anybody, I have seen some EMTs who I don't think are ready to progress in the profession take AEMT and fail. So maybe AEMT could be a good filter. So the question is, I don't know. I have to say the AEMTs I have encountered, and it hasn't been a ton of them, I have not been impressed. I have found a lot of lacking critical knowledge and clinical knowledge and critical thinking. I found that basically they're like EMTs who can start a line, hook up the monitor and go like, okay, now what? Like, it's like, what's the point?
Yeah. Yeah, I don't know. I mean, I do think it's I think having the EMT as the entry level still with the ability to progress to AEMT if that is what, like, if you're looking to do more, if you're interested in doing more, I think that is almost more beneficial because it's those people who are invested and are taking the extra step to then move into that role versus having that just be the entry role and then maybe eventually having that be kind of like I don't know if we end up just like the standards end up dropping for that as well. I
Yeah.
don't know.
And I hate to say this. This makes my skin crawl to say this. We do need people to staff the ambulance. I am not one of these people who is like, hey, like Jimmy is 500 pounds and can't spell EMT if you gave him a crayon, but he's got a card and, we need people to staff the ambulance. But I don't know. I don't know. There's not a good answer. So I go back and forth. Tomorrow I may think it's a good idea. Wednesday I may think, yeah, it wouldn't work.
Yeah, I think I've only ever worked with an AEMT just a few times, actually, when I was doing clinical rotations for when I was doing my paramedic program. I was down in like the DC area, and I think they have AEMTs down there. Not every place does. So
There was a guy who was working as an EMT in an area that I cover at one of my many jobs. And he is an EMT at this one job where I encountered him, but he is an AEMT at another job. And they responded as mutual aid into another county where there is a third service dual paramedic response. And he was talking about how he got into it with the paramedics on a code because they told him to slow down his bagging. And he said, no, you want the end title to be low. And he said the paramedics were like, no, you want it to be high. And he was like, can you believe these retards? And they think they're the top dog. And I was like, I straight up said, I was like, you are an idiot. I said, you are so dumb that you don't know what you don't know. And I know it was after that, I was just kind of like, it kind of poisoned the whole AEMT thing for me.
what? Wow.
I know. I
wonder,
was just like, oh God.
Okay, so not that it excuses like the lack of knowledge, but I almost wonder like if he was thinking about a different number, like a different thing that was supposed to be low and not the end title.
Oh no,
like,
he knew the end title. It was the end title.
Okay.
I just think, like, could you imagine if one of us did that back in the day? See, like, they accuse us of being mean to the EMTs say that we're mean and that we're not respectful.
I don't think.
And I said that if they went back to 2003 and had the paramedics that we dealt with, who were great, but if you did shit like that back then,
They'd be like, get out.
like,
Just, like,
like, I don't want to say names on the podcast, but Mike O would have thrown me down the steps in a row home at Wilmington. Anyway.
yeah. It's I don't think you guys are mean. I just think that you're tough and expect the basics to be done and done well. Like,
Know your job.
yeah.
I don't expect an EMT to be able to tell me about fluid responsiveness
Right.
in sepsis, but I do expect you to know that if you have a patient who is blue and gasping for breath and I'm not there yet, you should probably administer oxygen to that patient.
Mhm. Yeah.
All right, now I'm going to get accused by some other content creator who's up on a high horse of being mean to EMTs, but
We're not. And we could probably
not.
produce a couple hundred that we're, friends with and appreciate that would say otherwise. So sorry if it comes off that way, but that is not what we intend.
All right. With that, thank you, Ashley.
You're welcome. Thanks for having me.
All right. Goodbye.